All right. Welcome, everyone, to Citywide Medical Grand Rounds for today, October 23rd, 2025. My name is Dr. Madeline Verhofsek. I'm the Chief of Medicine at St. Joseph's Healthcare Hamilton, and we're the host site today. So we'll start today with the land acknowledgement. We acknowledge that St. Joseph's Healthcare Hamilton sits on the traditional territories of the Mississaugas and the Haudenosaunee nations, and is within the lands protected by the Dish with One Spoon Wampum Agreement. This is a treaty between the Anishinaabe, Mississaugas, and Haudenosaunee that bound them to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. So we'll move on to our next slide. It is my pleasure to welcome and thank Dr. Nadim Khalil, who is joining us from London Health Sciences today as a visiting speaker for IPAC Week, Infection Prevention and Control Week, on the topic of managing the measles outbreak in Southwest Ontario. I'm also delighted to have Dr. Zain Chagla today co-hosting in his role as Medical Director of IPAC at St. Joe's. And I'm going to hand things over to Dr. Chagla, who's going to tell us a bit more about our speaker.
So thanks, Dr. Rofsek. So thanks, everyone, and thanks for joining today. I first wanted to thank, it's IPAC Week, so I wanted to thank our dedicated IPCs and our directors across the city who have been providing great care in many contexts. And I think we're all looking forward to a post-pandemic slowdown, but unfortunately, an old foe in measles reared its ugly head and is the basis of what we're talking about today. So without further ado, I'll introduce Dr. Nadim Khalil. He's a MD, MSc, board-certified pediatrician and pediatric infectious disease specialist in Canada, United States. He obtained his medical degree from the American University of Beirut and completed a Master's of Science in Public Health at the London School of Hygiene and Tropical Medicine. Since 2021, Dr. Khalil has been a dedicated member of the London Health Sciences Centre, where he serves as the medical lead for infection prevention and control for the Children's Hospital. In addition to his leadership in IPAC, he provides expert care through his clinical work in pediatric infectious diseases. So with that, I'll turn it over to Dr. Khalil for what would be a very interesting talk on their experience with measles.
Perfect. Thank you for that introduction. I do first want to start with saying I don't have any conflict of interest to declare. It's definitely I'm quite happy to be invited, but I'm sad that we have to talk about measles in 2025. It's disappointing that we still have to encounter these outbreaks at this time of, especially with all the improvements we've had and with a lot of great preventive measures. But first up, I'll start talking about the outbreak, how it came about, describe it a bit. Then I'll talk about our experience at LHSC, different problems we faced, and how we overcome some of those. And then I'll finally talk about the management of exposed individuals. So first up, I want to talk about measles. It's quite a known pathogen that's been around for several millennia. Interestingly enough, diagnosis can be challenging. The first couple of days, it can start just with common cold, cough, runny nose, conjunctivitis, similar to any other community-acquired pathogen. Then, after a few days, a rash spreads. And that we'll talk more about, but from infection control transmission, it can be challenging to figure out. Then we talked about some complications, thankfully, which are rare, but definitely when you have a whole population that's affected, you do increase the risk of pneumonia, encephalitis, hepatitis, and roughly a 1 to 2% mortality. I do want to bring up a case for Complex Plus on the right. Those are pathognomonic for measles. They usually show up early in the phase and prior to the rash. Not every patient will have those, but if you do see those, they're quite concerning for measles. So talking about measles transmission, especially from an IPAC perspective, it's a pain to deal with. It's one of the most pathogenic organisms we deal with. And on average, every person that does get infected will transmit it to roughly 14 to 19 individuals. And roughly 90% of the susceptible individuals will become ill. We try our best to minimize transmission for other individuals, so people are usually contagious for 4 days before the rash appears and for 4 days after. Immunocompromised patients might end up having shedding a bit longer. Ideally, we do want to keep a patient in a negative pressure room and have people coming in either ideally immunized and wear an N95. The other thing is, because of the incubation period lasting so long, it's can be difficult to control it and where the outbreak that lasts so long.
So,
before talking a bit more about the outbreak, I want to point out to testing. Thankfully, with PCR in the last few decades, makes it a bit easier to identify anybody who does have measles. The tough part is getting the swabs. A lot of these patients you do have a good concerns for it before testing for measles, just because it can show up as a regular cold, or the rash can be non-specific. Early in the illness, you can find it in the blood and the urine, and then when the rash starts, you can see it more in the nasopharynx. Interestingly enough, serology might be falsely negative early enough with the IgM, and does take 3 to 7 days to become positive. And I do bring this up because prior to this outbreak, testing for measles was not common. Turnaround time was early in the outbreak was 3 to 5 days, which makes it very difficult to figure out who was sick, who was contagious. To take any measures was quite challenging. As the outbreak progressed, we had to reach out to public health lab, and we were able to get serology testing locally in London. We were able to get those turnaround time within 24 hours. And then the PCR was done in Toronto was also turnaround time with roughly 1 to 2 days. So that helped a lot figuring out diagnosis and figuring out who got exposed. Talking about our outbreak, I'm quite sad to say that this is the largest measles outbreak in North America since the 2000. We had 2,375 cases confirmed or suspected. The previous largest one was in Montreal a decade ago, and that had only 725 cases. When this outbreak started and we tried to reach out to some of experts around the country and the US, the lead expert at that point was somebody from New York, and they only had 75 cases from a super spreader event. So even though it's an old organism, the healthcare system has changed. It's a different patient population. So there was a bit challenges. And then thinking of why it happened now, we've had some intermittent cases, the vast majority of people coming from abroad. But this time around, it was a cluster of unvaccinated individuals. It did start in the Atlantic. Some of those patients were interacted with those and came back to Ontario. And we got these clusters of individuals were close groups where they met closely. They had low vaccination rates, and they were not really willing to get support in there. And then also we need to take into consideration the recent COVID-19 outbreak. People are not as accepting of vaccines as they used to be. Their primary care system has taken a big hit. People don't have primary care. So things are a bit challenging to get the vaccine. So it's a bit of it's all compounded to this major outbreak. So like I said before, this started back in New Brunswick, and then we had some cases transferred here. And then we started some steady increase starting in January, February, and then peaked in early spring. The good thing is we haven't had any cases for the last few months, and the outbreak has been declared over on October 6th. Part of declare that over, we need to wait for 2 times the upper limit of the incubation period, which is 21 days. So 42 days after the last rash, Ontario declared this is over. And I do want to point out this was consistent with what we call a propagated source versus a single source. So we had transmission going around from one place to another. So this shows up a map compiled from Ontario. So what we did see was the vast majority was in Southwest Ontario where we work, and it was spreading from one place to another. I will say that was a bit of a blessing in disguise because it did limit the impact on the healthcare system. So we were able to see a steady kind of streaming in of these patients coming in versus the floods being open in.
So
one thing we did notice is the vast majority of these cases were in young children, less than 20 years old. The vast majority were unvaccinated, which kind of is interesting because the parents are usually either immunized or had contracted measles when they were younger. The vast majority of these were confirmed cases, and a few were probable because they were in the household or not willing to get tested, or public health asked them to stay at home or do some home testing. I do also want to point out, even though this is one of the largest confirmed outbreak, we do suspect that there was actually the number was several magnitudes larger, at least twofold, if not even 10 times or 100 times, just because a lot of patients might have had mild symptoms or did not want to seek care because they didn't feel sick. There was 165 hospitalization, 12 ICU admissions, and 1 death, which we'll talk a bit more later on. As I was saying, the vast majority happened in children, and they were unimmunized. We did see some breakthrough infection, but that was quite rare. We do know that the vaccines are quite effective, with the 2 doses having efficacy of 97 to 99% efficacy. The one great thing is, for those that did have breakthrough infection, they were self-limited, it was mild, they need to be hospitalized. And to my knowledge, talking to public health, there was no secondary transmission ever reported during this outbreak. So moving on to our experience. So I'll talk about some of the problems we faced and what we helped, and we did. So as the cases increased, beginning of February, IPAC kind of raised the alarm. We're seeing an increase in number of cases in the hospital. We need to take some measures to make sure everybody's staying safe and healthy, from patients, family members, other staff as well. And so kind of we tried to think about what are some ways to help people safe and where transmission could occur. Especially in pediatrics, the patient does not come alone. It does take a village to take care of a patient, and especially a child. So usually they come in with their essential care providers. So we have to think about family members, of visitors. So that affected, what if they were recently infected? Do we worry about family members roaming around the unit? Do we need to worry about patients that were recently sick? Maybe they're no longer contagious. Do we need to worry about their family members? Do we need to do any measures for that perspective? We also need to keep our staff safe. We do want to point out that Children's Hospital is part of a bigger adult hospital. So LHSC is 2 hospitals with almost 1,000 beds. The Children's Hospital is only 150 beds with 11 ICU and 50 NICU beds. So kind of any measures, we talked, since it was mostly pediatrics, kind of any measure at the doors of the hospital is a bit of a challenging. So those were a few things. And then the big thing was actually talking about the community. So the vast majority of these cases were coming from outside. And the interesting part is we were kind of the eye in the storm. So the middle part here is London. So we see the white spot. We didn't have a major problem in the city of London. So when we did see this increased number of cases, IPAC, we reached out to the Children's Hospital administrators and leadership to get some support. We reached out to public health, and the response from public health, we don't have a problem in London. We have 0 cases here, and we're really not expecting any problems. So the vast majority of these were from surrounding areas where we take care of. And we see here a breakdown of the most common public health where measles was diagnosed. And we serve this community, and 80% of the cases were in communities surrounding London. So even though we didn't have a problem in the city of London, we were worried about all these patients coming into the hospital, potentially being contagious, interacting with other individuals, and getting other people sick. So even though in the city itself we were fine, we were worried that we might have an outbreak from the hospital. So the big ones we saw from cases-wise were Southwest Public Health was the biggest one. We saw here in Perth, Grand Erie, and again, it was spreading from one place to another. And again, I do want to point out to the immunization rate, and this is for London, but for most communities, we still have high rates. The biggest problem was these select communities that were closed off, that were just spreading it, more or less super spreader. And we did have super spreader events around weddings, We did see some with Easter was a big one. But again, that's the reason why London didn't feel a problem, because it was, even though there were some select unvaccinated individuals, they still had a decent herd immunity, and we did not expect we were going to have this major outbreak in the city itself. Talking about what we saw, so again, as January came in and early February, we saw an increase. So we saw overall 63 admission out of 165 admissions in Ontario, so roughly 40% of cases. We also had 7 ICU admission out of 12, 6 in pediatrics. We did have 10 pregnant individuals and 2 babies born with concern for congenital measles, which I'll talk at the end about that. The vast majority of patients transferred to us were because of respiratory failure, hepatitis, or encephalitis. And thankfully, everybody did well, and we didn't have any mortality at London. So first up is the first problem we faced were patients themselves. And part of it was wanting to minimize transmission for them and keeping everybody who's coming in, even for something elective, make sure that it was still a safe environment for them. And part of that was crowd control, because we basically want to protect those at the high risk of getting severely ill, and those that didn't have a good protection, or if they've had been vaccinated with not a good response, or they'd have high mortality if they were sick. So that included children less than 1 year, especially those are premature, and those less than 6 months of age. We were worried about oncology patients because they are immunocompromised, might have a more disseminated disease, they might have longer shedding, and actually, even if they were just exposed, people might not be comfortable proceeding with their treatment. So even an exposure in the oncology ward would affect patients' primary treatment and could actually lead to worse outcome from that perspective. And then lastly, pregnant individuals, their immune system might not be as effective. There have been reports of breakthrough infections despite vaccination, and we don't know what the impact is going to be on the babies themselves. So we were worried about patients themselves coming in, being contagious or incubating. We were worried about essential care providers, because patients, especially pediatrics, don't come on their own. We were worried about parents coming in, visitors that are potentially walking around inside the hospital on the wards. And then lastly, we were worried about staff coming in from some select communities. They could be contagious, or they could actually transmit or get infected themselves. Interestingly, some areas we had difficulties that we didn't account for are some shared adult and pediatric spaces. It was easier for inpatient wards to put some boundaries, but then for shared spaces, because it's predominantly a pediatric problem, talking to MLHU, so the Middlesex London Health Unit, and to our adult colleagues, they didn't think there was a problem. And they said, we have no cases. Our adults are usually vaccinated. Visitors are going to be older, they're vaccinated, or had acquired measles when they were younger. We're not expecting a problem here. So we tried to make a matrix, trying to assess for what's the probability of somebody getting sick, what's the severity of it, and try to provide targeted recommendation for every specific unit. So for the pediatric sites, we realized everybody that's both inpatient and outpatient fell under a high-risk unit. So it was we closed those units. It's easier when pediatrics, because people need to come in from a protective perspective to buzz in or be let in. So it was easy to set up a screening at those entrances. We selected for active screening because we were worried they might not be reading the signs or not respectful, still coming in when they're sick. Then we also were worried about some adult mixed. We decided to do some active screening to keep patients that were potentially at high risk going into those units. But then compared to the adult side, a lot of it was for visitors, was more passive screening because they weren't worried about that much transmission. So this is one of a template that we use for measles screening. We were thinking about common things. So usually specific rash, a rash, cold-like symptoms, but then think about something more specific. So that's going to be the Koplik spot and conjunctivitis, which you wouldn't be expecting somebody with common cold. But then we did also want to assess for somebody who could be incubating, who've been requested to stay at home because they got exposed the last 3 weeks. And we did ask these for everyone, regardless of their vaccination, because breakthrough, even rare, could still occur. which also led us to trying to see who had proof of immunity, especially we talked about staff and essential care providers. Ideally, we did want 2 doses of MMR vaccine after 1 year of age. We were prioritizing MMR vaccine because even though serology can be helpful, you can still have some false negative or false positive. We did, for the future, looking at somebody who was diagnosed with measles with a PCR or IgM positive, those could be used for the future, saying they'd have natural immunity now. And interestingly enough, public health did suggest the cutoff of 1970, and it was quite useful. So 98% of cases in this outbreak occurred in individuals born after 1970. For patients when they're coming in, ideally we did want to put them in negative pressure room, have people wear an N95 when they're going in, minimize transmission. So this way, any air is not circulating and pushed to the outside. So you're minimizing transmission that's up in the air that's being aerosolized. Thankfully, we didn't have any major issues with our room. We have a good number of negative pressure room for our pediatric sites, better than adult colleagues. But we did set up, what if we don't have a room and reach our maximum? So we did suggest a private room with a door closed with a portable HEPA filter would be a reasonable alternative until we can find them a nice negative pressure room. We did not have to cohort, but that's also another thing we discussed. One thing that was brought up to us was the emergency room. That was actually the biggest port of entry to our hospital, people coming in with measles or symptoms concerning for measles, and they didn't have that many rooms. So we just want to make sure that we had a good turnaround time and make sure it was safe to use the room as quickly as possible. So we looked at the air exchanges, talking to our facilities. So that's a number of how quickly things are circulating. And based on that and the pressure gradient, we can calculate how quickly 99% of aerosolized particles are being sucked out and when the room is safe to be used. And we do want to point out that cleaning during that foul time is safe as long as the people going in have a proof of immunity or vaccinated and wearing appropriate PPE. So in some select places, within 30 minutes, another patient could come in there. The other big problem is family members. So in general, children, they're younger, they had to have somebody help assist, provide them help, especially if they're breastfeeding, for example. For the vast majority of these children, they were either suspected to have measles or being worked up for measles or confirmed measles. And we tried to prioritize individuals that were immune, because again, even though the kids themselves might not be immunized, parents either had measles when they were younger or coming from different places where they've had the vaccine. But if they did not have a proof of immunity, we actually requested they were staying in the room, avoiding communal spaces. And similar to what we do with a breastfeeding parent, we actually were trying to get a tray to the parents so they can eat as well when they're isolated. So we kind of were asking about symptoms, exposure, their immunity. We did ask people to come in with their vaccine records. We did ask the public to reach out to bring in the vaccine records or reach out to public health if they have their records, because that might be the other step. Or people moved away, they might not be able to contact their family physician. But again, this was not always feasible. So in high-risk units are people that were in there for a while, especially for our oncology patients or NICU. We did help getting their serology tested so they could come in. The one thing we did notice is, let's say a patient came in for appendicitis, but a week ago were diagnosed with measles. So even though the patient is outside that incubation period, they're no longer contagious 4 days after their rash, we can't say the same about their providers. So parents themselves could be then contagious. So we actually sometimes had to keep patients longer in a negative pressure room, not because of the patient, but because of their surrounder. But also we kind of closed off some of our public spaces and asked some people not to show up. And the tough part is the extent of our interventions ended at the doors of our wards. What happened outside the wards is difficult. So these patients might end up going to the cafeteria, might end up going to grocery store. We try to request as much as possible not to go into those places, but the extent of our we couldn't do anything beyond that. Again, we were prioritizing the MMR vaccine, and that was the difficulty getting the proof of immunity. As much as we want to trust our patients and their family members, taking their word might not be enough, because there's a subset of individuals between 30 and 51-year-old who potentially only got one dose. So before 1970, we were assuming everybody got natural infected, they're immune, but then we introduced one dose of MMR in the 70s and 80s, and then 2 doses was routinely introduced in the mid-90s. So between the 70s and 90s, a lot of individuals were getting only 1 dose. So asking them to just, are you vaccinated or not? To their knowledge, yeah, they were following the recommendation, but they potentially got 1 dose, but they're still susceptible to that. And so that was one of the challenges we've had. We did kind of talk to the communities. We did ask them to not come in when they're sick. We asked them to get their vaccine records. We put some signages. We did some active screening. We posted some frequently asked questions. We just sent out some communication releases, and we did have those signs translated in High German just for those individuals that were coming in from areas that where English might not be their primary language. The other problem we saw is communal spaces. We talked about the waiting rooms was a big issue for us. We didn't account for in the first couple of weeks. We thought, okay, it's going to be mostly patients. But as we were contacted about potential exposure, potential patients coming in, waiting in the waiting room, in our emergency room, and our outpatient, we realized we need to do something different. So initially, when we started recommending screening, this was happening at time of triage, especially in the emergency room. So people were being registered, going back to the waiting room for potentially 10, 30 minutes, ready up to an hour, where they could be contagious. Before then, they were being assessed by a nurse. Then they're realizing you were actually potentially contagious. Let's get you out of there. After a week or two of screening through patients' charts for potential exposures, we decided this is too much. I need to find a solution. And so we talked about, can we actually switch our screening at time of registration? We do have to admit that these providers were not medically trained, but and potentially adding an extra step for their work. But what happened if patients were failing screening, concerning for fever, rash, spots, or exposed, were quickly being taken out of the waiting room and assessed. And if they were deemed unlikely to have measles, back to the waiting room, or if they had high concern for measles, switched to a negative pressure room as soon as possible. After that, we actually didn't have any exposures happening in those waiting rooms. So moving on to staff. I'm happy to say the vast majority of our staff had proof of immunity. We did have some that were working at LHSC for quite a while that didn't have record. We didn't have their records, so we did reach out to them. They were kind enough to get tested or proof of vaccination, and the vast majority of our staff didn't have a problem and didn't have an issue there. One problem we did face is pregnant individuals. So in Ontario, there is no contraindication to providing care if you're pregnant. And because we assume you've been vaccinated, you have proof of immunity before coming on, before providing care. The problem is you can have breakthrough infection, and we do have limited information what's going to be the impact of measles on babies. So for us, we try to encourage finding an alternative assignment whenever possible, just because vaccine failure can occur. And anecdotally, during that measles outbreak in Montreal, there were some individuals who were pregnant that did have breakthrough infection. None of that data was published, so I'm not sure how many individuals and what was the outcome. But again, reaching out to some providers, that's what was of a concern. So next is what happened when all of these measures failed. So what happened if there was an exposed individual? So first up, we're trying to figure out what's the extent of the exposure. So we assume somebody coming in for 30 minutes before the appointment potentially was in the waiting room at the same time, or somebody that was there for a couple of hours after the index case left, just because of these particles being in the air, being inhaled by people coming in. So for us, we did actually have one, and so I'm ashamed to say it was in our ID clinic. So we had reached out to the family, made sure to get their, if they're symptomatic to come in, they passed through our screening at the doors. Family said no problems, but then when the provider went in, they noticed this patient has a rash. That actually just popped up in the last couple of hours. Thankfully, this was on Friday afternoon. We didn't have too many issues. We didn't have too many patients there, but again, it makes it a bit challenging to get testing done on a Friday afternoon. You were not going to get the testing result till Monday, which makes it difficult to give post-exposure prophylaxis because we do have such a narrow window. So we had to figure out who was exposed, figuring out if they were high-risk individuals, figuring out if they had their vaccines, figuring out do we need to isolate them? Are they being admitted, or are we going out to the community? So the vast majority, if they're healthy, you'd ask them to isolate for 5 to 21 days if they don't have a proof of immunity. However, if we can identify somebody that's exposed and give them their MMR within 72 hours, you don't need to isolate. But somebody who's immunocompromised, who can't get the MMR because of multiple reasons, then you would give them immunoglobulin, and you'd have to extend their isolation up to 28 days just because breakthrough infections can still occur. And that's kind of talking about what are some medications we could give as post-exposure prophylaxis. So for healthy individuals, if we can get them within 72 hours, great. We can get them the vaccine. But somebody who's immunocompromised, for example, infants less than 6 months, pregnant individual, or immunocompromised, the vaccine might not be safe or not studied, or it might not be effective. So immunoglobulin would be the preferred choice for those individuals. For the MMR vaccine, it's quite helpful if it's given within 72 hours. It can vary a bit in their efficacy. From some reports have been published between 80 and 100%. The difficult part with the MMR vaccine is such a short window. You have to figure out the patient has measles. So you have to have a high index of suspicion that this rash was measles. So we have to go think that it was measles, get testing done, send it out. If you get serology done, maybe within 24 hours. If it's a weekend, you might not get it back till Monday. So you can have up to 48, 72 hours. Same thing with the PCR. We have to ship it out to Toronto, so it might not work on the weekend. So sometimes by the time you get the testing result, you're getting close to the 72 hours. Then you have to reach out to public health. We have to notify them. So public health sometimes need to reach out to these family members, tell them you were exposed, please come in, do you have your records? Come in within those 72 hours to get the vaccine. So as much as we can, it's not always feasible. Then on the other side, so high-risk individuals or those that cannot get the vaccine can get the immunoglobulin. We can do that within 6 days. However, starting day 5 and onwards, you would actually need to bring somebody into a negative pressure room, just because that it could be on the earlier side of their incubation period when they could be contagious. Again, most of the time, it's around 10, 11 days, rarely 7 days. But again, to be safe, because you might not be sure when the exposure happened fully, you start counting from day 5. The other part, again, efficacy can be variable. So a lot of studies happened from a mid-1900s showed efficacy was great, but we do worry now that most of the people that are donating plasma had immunity from vaccination. So you might not have as high of circulating antibodies, and so it might not be as efficacious as compared to immunoglobulins that were given prior to vaccine was around. And again, like I said, then isolation was still required, which gets us to logistics. So we had to think about immunoglobulin, giving it as IM versus IVIG. We had a good supply of IMIG supplied by the Canadian Blood Services, but there's a continuous IVIG shortage. So we had to be smart about who can get IVIG. The other part with IMIG, it's great for young infants. You can get an IM injection. They're in and out there before the incubation period can be fairly simple. But an individual that is exposed, you can still give immunoglobulin, even though they're not infant. But the problem is it's 0.5 ml per kg to a max of 30 kilos. So as you can imagine, theoretically, you can get a slightly older child that was exposed, and you're giving them 15 ml of IM fluid. The vaccines, what you're getting now is 0.5 ml. If you're giving ceftriaxone IM injections, a few ml. So you would be giving 4 or 5 injections. So even though theoretically it's possible, realistically it's not feasible. So that was one of the challenges we've had to think about. The other problem is, can we do some of this as outpatient? We talked to public health, and again, not feasible because we do require blood bank to store these medications. So, and we have a very limited number of outpatient rooms. So these patients were coming on the weekend after hours. They had to come to the emergency room. Thankfully, we did set up a system to streamline it. Public health would reach out to the ED, make sure there was a room available. So these individuals were now waiting in the waiting room, coming in, getting their infusion as quickly as possible, monitor for the adequate time, and then discharge as soon as possible. So we're not affecting other people's care. So I know this is a bit of a busy slide. I'll try to simplify it. So we talked about post-exposure prophylaxis, and we talked about the vaccine. So it's group 1 and group 3 are a bit easy enough. So group 3, these are low-level immunocompromised patients. They've had their measles vaccine. They're on a bit of steroid because of an asthma exacerbation. We think their immune system worked. They've had a good response to the MMR. Doing nothing is safe. On the opposite side, group 1, these are severely immunocompromised. These are patients getting their chemotherapy, just got a transplant. They are ALL patients or have AIDS. We don't think, regardless of their vaccine status, we don't think they've had a good response. We don't think they're protected. For those individuals, simple enough to give them immunoglobulin. The biggest headache was actually group 2 in the middle, where we have, sadly to say, no clue what to do. These are because in the last 30 years, when these biologics came about and we started using them more and more, measles was not around. So we actually have no data about how immunosuppressive these medications are, how much their previous immunization is still effective. So it's really depending on the patient, what they're getting. There was a discussion with the primary team, public health, with infectious diseases to figure out, do we need to do anything else? Is doing nothing is safe? Is checking serology is okay? Or do we are really worried about these patients that could impact their care? Do we give them immunoglobulin? Then the last couple of challenging patients we had to deal with were pregnant individuals. So this one was actually thankfully ended well, but we had a potential outbreak and exposure on Easter weekend. So on Thursday afternoon, we had an individual coming in because they were feeling unwell and had a fever. Yes, they were coming from those communities that were isolating, but they didn't have a rash. So but within 24 hours of being admitted, they had a rash. We did send them for serology testing, and the PCR came back fairly quickly, positive. Yep. So this was actually a best case scenario. Everybody that was exposed were assessed in the waiting room, as was trying to figure out if their risk of being sick, of being contagious, other individuals with them. So we had to think about their spouses. We had to make sure that the pregnant individuals themselves were not going to get their newborn sick. And because it was a long weekend, we can use any of our outpatient support. So we can reach out to public health to facilitate with following up with these individuals or getting them the MMR. We can reach out to family physicians to get their MMR there. So in the middle of the night, we reached out to the charge nurses, to the residents, and we assessed everybody's, because at that point we had a bit more streamlined. People did have their vaccine records or serology tested done. So we were able to assess for immunity. And thankfully, everybody was deemed as susceptible, got their MMR vaccine within 72 hours, and we didn't have any issues. The people that were exposed had delivered, because this was under labor and delivery. So thankfully, nobody was pre-delivery at that point, because it does affect our management. Because a susceptible individual theoretically would need IVIG, because if they don't have proven immunity, because it can be severe, and the MMR being a live vaccine is not studied in those individuals. But for us, thankfully, we got lucky and everybody was they had just delivered and so it was safe to get them MMR, and we got lucky to give it within 72 hours.
So
then moving on to the last topic for today is congenital measles. So this is an old disease, but a new problem. So that's something we want to bring up to this outbreak. Yes, we talked about our experience with LHSC. And even though measles is a well-known pathogen, it's not the same healthcare system that it was 20, 30, 50 years ago. And this was actually surprisingly a problem we didn't initially think about. And there's very limited data. So in the olden days, pre-vaccination, people have had likely contracted measles in childhood. And by their time they reach childbearing age, they're immune. Or for the vast majority after the vaccine came about, people got the vaccine, they're protected, measles not circulating, it's not a real big problem. But now we have a new issue. What do we do with pregnant individuals that are not immunized, never contracted measles when they were young, and now being sick with measles for the first time during their pregnancy? And unfortunately, there's very limited data. Biggest cohorts include 10 individuals, very poor following up. Every person did different things. It's unclear the efficacy, very poor outcomes, or unclear long-term issues. So we were a bit in the dark, and we did have problems. So there was one case of mortality. The patient was born close to LHSC, had a brief visit here, but then was transferred to sick kids because of the underlying cardiac problem. And the problem here was this patient was premature and actually had concern for shedding for quite a while. It did help a bit because after this case came about, some individuals from those communities took this more seriously. They had reached out to us, okay, now a death occurred. We are worried that this could affect us or our children. What can we do to protect us? So it was a bit of a blessing in disguise. So the problem were, it's a rare complication. So these patients could born sick. They could born with measles. They could be contagious. They could have longer shedding. And we are at this point in our medicine, we are relying on PCR for diagnosis. And PCR cannot differentiate between live virus or dead virus. So even though you're testing positive, it's unclear, are you so contagious? And almost nobody will do a culture. There was no guideline. There's very limited data. And that did impact patient care and how to manage them. And want to make sure also, like we talked about, our NICU was deemed a high-risk unit. So they do have a ward. So you have sometimes 4 up to 8 patients in one place. So if you bring one patient that's sick, all 8 of those could get sick. And because they had high risk of complications, you could end up causing a lot of bad outcomes to patients in those wards. The other thing I want to bring out is there's a high risk of SSPE in these infants. So while not common in older children, and that can happen, so that's a neurological devastating issue that can happen when you're a bit older. So usually 10 to 15 years later after being measles and with no treatment. Patients born with measles could actually have SSPE within a few months. And so, or a few years, so which is way more aggressive compared to older children and at the higher rates as well. So I just want to bring up a few different cases that we've thought about, and we've created a different algorithm to help assess both locally and our surrounding sites. So first one is fairly simple. So this is a parent that was diagnosed with measles a week after they were delivered. So the baby was deemed potentially exposed because they were breastfeeding, or around the surrounding area, she would give them immunoglobulin because they're less than 6 months old. You cannot give them. Then we would put them in isolation for 5 to 21 days and up to 28 days if they agreed to get immunoglobulin. The other challenging part I do want to bring out is a lot of these individuals were against any healthcare intervention. They were against the vaccine, and sometimes they were against blood products. So it was a bit challenging, and we couldn't reach out to CS because it's not proven to be super effective. But again, one other problem we had to think about and to explain that yes, you don't want to get a vaccine. This could be helpful, and sometimes they would refuse it. So coming to a bit more challenging cases. So this was an individual that contracted measles earlier in their pregnancy, delivered a bit while ago, a couple of months after. This impacts actually the pregnancy itself much more than the baby. There's a high risk of miscarriage. There's a risk of prematurity. And we decided just to monitor the infant. If they had symptoms concerned for measles, we test and isolate. But potentially, if it happened that while ago, mom's immune system would actually end up passing immunoglobulin to the baby, and they would be protected at that point. The biggest problem was these babies born to somebody who's just got diagnosed with measles at the time of delivery. So the one we talked about is as part of our exposure. So what do we do with the baby? And this is where there was very limited information. So we defined congenital measles as a newborn who had symptoms within 10 days of birth. And that's what other people decided to. We extended that for 14 days just because it's a nice round number. We were worried about moms being sick in the past 2 weeks prior to delivery as well. Can lead to severe congenital disease. There's some reports saying immunoglobulin can help, but again, it's for small studies, not an RCT. We offered it, but again, it's unclear how much benefit it's going to provide. From infection prevention perspective, these were a bit of a mess because they would be in our negative pressure room for an unclear period of time. You have a limited space. They're there for several weeks, if not months, because they're born early. You want to make sure you're not getting anybody else sick. And so we decided to keep them in a negative pressure room. We decided for a zero risk transmission because again, it's a high risk population. We decided to do weekly PCR. Might be overkill. We won't be able to differentiate between active disease or old disease. But again, want to make sure we didn't put anybody at risk. The baby that passed away when we reached out to sick kids was still tested positive on PCR 2 months after birth. So it was tough. And then one thing we didn't talk about, we talked about in utero transmission, but you also have to keep in mind of potentially mom being contagious at the time of delivery. If they were coughing in the room themselves, we were worried about amniotic fluid being aerosolized and the baby inhaling that. So that's also another concern to think about. So just kind of a summary. It's an unfortunate thing that happened and horrible that we have to deal with this in 2025. A couple of good things is we didn't have any transmission that we know of that occurred at the hospital. We didn't have any visitor families come in sick when the patient did not have measles. So we put these barriers because we were worried about something coming from the community, but thankfully that was that worked out. Even though breakthrough infections occurred, none of those that were vaccinated were contagious and they had mild disease. And overall, I would say we got lucky. So with one fatality, so one in almost 2,000 cases is quite fairly low. And I think that was the best case scenario. And this one, it's unclear how much measles played a part of it because they already had other medical problems that likely played a part in that. So kind of moving forward, looking for the future, and I thought about this. What could we have done differently, and what can we do to prevent this for the future? And this is my wish list that I'll submit to Santa, and hopefully I'll get it by the end of the year. So I wish we had better vaccine rates. I wish we didn't have to deal with measles 2025, and I didn't have to worry about it. I wish we had a better vaccine registry to figure out who's been vaccinated and where are they, and that tracking these patients. I wish we had more negative pressure room, so we didn't have to worry about putting patients or cohorting or not being in the right place and being contagious. I wish we had a better way where we shared information, where people are being potentially tested for measles, suspect to have measles, and then they end up showing up in our emergency room or being admitted and we have to backtrack. And I do wish we had some more information about congenital measles or patients with group 2 that are immunocompromised. But for that one, actually, I'd be fine without it because that means we had much more transmissions for measles, and I'm okay with that. So overall, I do want to say thank you for giving me this chance to present our information. I want to say thank you for our IPAC team, which was amazing, and for our leadership that was very supportive to all of this.
Wonderful. Thank you so much. I saw some hands clapping there, and many thanks for sharing your academic and practical hands-on expertise from what has been a very unique time of measles outbreak. So we'll invite some Q&A now. And again, welcoming back Dr. Chagla as co-moderator and co-host with me. I see here a question from Dr. Mertz, which I'll read out, Dr. Khalil, and which I think you can see as well in the Q&A. And then I'll hand things over to Dr. Chagla. I see that Dr. Holbrook has a hand up. So from Dr. Dominic Mertz, great presentation, thank you. Your table with the fallow time used until reusing an exposed room seems to be longer than what is often recommended. For example, 35 minutes for 99.9% removal with 12 air cycles per hour. How did you decide on the durations you used? Were you adding an additional buffer just in case?
Yeah, I can share that again. That slide for those that might not be familiar with fallow time as much. So part of it was simplifying it. So yes, you do have great tables to identify what's the fallow time for every air exchange, but we decided to group things together to make it a bit easier for some individuals and to get a good round number. So yes, we did round up for simplicity's perspective and to account potential for some issues with testing.
So great. Thanks.
You. Yeah, thanks for that. So I'll go to Dr. Holbrook if you want to. I think you should be able to unmute, Anne.
Let's see.
I lost it. Okay. Yeah, it's okay.
There you go, Anne.
Just was delayed. Thanks, Anne. Well, thanks for an excellent talk, Dr. Khalil. That was really impressive. And in the background, it's always so impressive to see what our public health colleagues are doing, in very unrecognized, I think. So my question, you can't see all the gray hair here, but there's a few of us that remember Ontario before measles vaccine was available, before any of the vaccines, and the carnage that ensued amongst all of our families. Being the oldest, going into grade 1 meant, missing a month and a half of school because you got every virus going. So my question is, moving forward, what have we learned about the vaccine hesitancy problem, the enormous amount of misinformation and the sort of clustering in certain communities where therefore measles and other infections are very vulnerable? I'm reminded that Mark Loeb had done a study amongst the Hutterite community in the past and made some headway there. Just wondering, what are the efforts in public health or in research to really kind of combat these clusters of vaccine hesitancy and get vaccine rates up again?
Yeah, that's a great question. I think that's something we talked about a bit with different public health. And like I pointed out, with Middlesex London, we didn't have that much of an issue. We did reach out to Southwest Ontario, where they had the highest rate, and they had tried to get buy-in with those communities. And I do want to point out it was actually challenging for providers because we've been recommending vaccines for quite a while. We do know they're safe and effective. And it's tough when you've been disregarding our suggestions in the past, and we come in sick and you're hoping for a treatment that does not exist. So it's kind of tough. Actually, we did have an ethics round about it, what's the impact of it. And part of that, we discussed what's the cause of this hesitancy. And it turned out it's not uniform. So everybody says it could be religious, but actually none of the religions are against it. And so, I know we're talking about select communities, and it's really depending on the elders in those communities that actually dictates if they get the vaccines or not. So it's not, and so you might have some communities that are a bit more modern, let's say, are willing to get the vaccine versus some others that are not. It's really depending on the other. So it's really one person in there that's making that decision. And you try to give them information, try to work with them, you try to get in there, you try to convince them. But sometimes people have made up their mind because they've been preaching for this for a while. The fact that we have an outbreak now, that means you have at least 20 to 30% of that community is under-vaccinated. And for that to build up, it's been 20, 30 years when people haven't been getting the vaccine to be below those herd immunity to have those major outbreaks. So I think people are reaching out, but it's quite challenging and it's sad. I can't say except it's heartbreaking, especially with the current political climate, especially when we look across the border. And I'm sad and I'm scared. This actually just came into my role as IPAC, and I came in early with this outbreak, a month and a half before I was supposed to. So it was a trial by fire. And I'm worried about the future. Yes, we're going to have more and more vaccine preventable outbreaks. I am worried that in the next 20, 30 years, we're going to be back where I'm at now with another measles outbreak because these communities are not going to be vaccinated. They're going to have more children that are under-vaccinated. And unfortunately, people are not willing to listen to logic, and misinformation is super easy to spread out. All of these big platforms want this misinformation. It gets clicks. And that's the sad part is it's easy to inflame people. It's easy to get them scared. It's easy to get them worried. Because if they come up in the news, tell them there's no measles, everybody's great, everybody's healthy. People don't listen to the news, they don't click. Versus we tell them, oh, you might get sick, don't do that. People are debating about it. And so it's a bit, it's scary. And I think people are working and people are looking, figuring out for social media, but I am worried that this is just the beginning of this. And this is for a vaccine preventable disease, and there might be a new outbreak. And we kind of felt with COVID, with all the measures we did, people are not willing to take the vaccine now, even though it's effective. We're seeing more cases of COVID than we do see for flu. We've had several mortalities already this year because of COVID this respiratory season. And if you ask the communities, are you getting your vaccine? And people, no, why would I? We already lost that one, and COVID wasn't mild, but still fairly mild compared to, let's say, Ebola. Like mortality was still fairly low to what could be, and so it's scary. It's I think we've been getting these practice runs, but one of these days we're going to be hit massively, and it's yeah.
Thanks for that. Yeah, and I think the reality, as you were mentioning, is measles is not a disease that's insignificant outside of Canada. It may not be insignificant outside of North America. There are active outbreaks in many parts of the world, and the chance of we get alerts from the airport every day that someone has walked in with a measles case, right? So it's just these little embers that eventually can hit the right bundle of dry leaves that explodes in a flame, and unfortunately we're gonna continue to see these embers moving forward.
Yeah.
I think that takes us to time, though. So I first of all wanted to say thank you on the behalf of IPAC Week of our team. I think we really wanted a compelling discussion around what happened with measles, and you were able to provide it to a significant degree today. And I think all of us reflect on the experience that you went through and all the multi-stakeholder involvement that's involved. Maybe I'll turn it over to Madeline if there's anything else.
Yeah. So thank you so much, Dr. Chagla. And once again, huge thanks, Dr. Khalil, for joining us. Thank you to everybody who logged in and participated today. Medical Grand Rounds will be back next week, October 30th, with HHS as the host site. And the week after that, November 6th, Chairs Medical Grand Rounds. So keep an eye on your email inboxes for further details. Thanks again. Have a great day and a great week ahead. Take care.
Thank you.